Hello students, in today's video we are going to discuss analogues of thyroid hormone with reference to L-Thyroxine. We will also try to understand hypothyroidism, its types, causes, signs or manifestations, and the use of L-Thyroxine in the treatment of hypothyroidism. Now, as we all know, thyroid gland is a butterfly-shaped endocrine gland located in the neck region. Now, thyroxine and triiodothyronine hormones are secreted by the thyroid gland. Thyroxine consists of 4-iodine and therefore it's popularly known as T4, whereas triiodothyronine consists of 3-iodine and it's known by the name of T3. Now, thyroxine and triiodothyronine are collectively together known as thyroid hormone. Now, main function of T3 and T4 is to regulate basal metabolic rate, that is BMR, and these are very essential for the overall growth and development of the body. Now, let's understand what are thyroid hormone analogues. Now, thyroid hormone analogues are synthetic compounds that have molecular structure and functions similar to thyroid hormone. So, thyroid hormone analogues are the compounds with structure and functions similar to T3 and T4. Now, here it's very important to understand the term hypothyroidism. Now, hypo means less. That is when thyroid gland is underactive or when the thyroid gland is less functional and it produces less T3 and T4, not enough to fulfill the requirements of the body. Then this condition is termed as hypothyroidism. Now, this deficiency of T3 and T4 in the body is fulfilled by the administration of thyroid analogues. So, thyroid analogues are used as replacement therapy in the treatment of hypothyroidism. Now, L-Thyroxine or levothyroxine is the analog of T4, while L-Threonine is the analog of T3. Now, very important to understand here is this, that T4 hormone, that is thyroxine, is largely inactive, whereas T3 is active. And in our body, this inactive thyroxine is converted to active T3 by many organs, most important being liver and kidneys. So, L-Thyroxine sodium is a synthetic analog of T4 and is chiefly used in the treatment of hypothyroidism. Now, as discussed, L-Threonine is a synthetic analog of T3 and it is used occasionally along with levothyroxine in the treatment of myxoedema coma. Now, here very important to understand, myxoedema coma is a severe form of hypothyroidism. It's an emergency that requires immediate treatment. Now, clinically, L-Thyroxine is the drug of choice in the treatment of hypothyroidism. Now, let's understand why L-Thyroxine is preferred over L-Threonine. Now, L-Threonine has a shorter half-life and it requires repeated doses and thus its response is less predictable. While levothyroxine has a longer half-life and therefore it is administered once daily and it shows sustained and uniform action. Now, in addition to this, L-Threonine has increased risk of cardiac arrhythmias while levothyroxine has a lower risk of cardiac arrhythmias. So, before discussing pharmacology of L-Thyroxine, let's understand hypothyroidism in detail. Now, as already discussed, hypothyroidism occurs due to reduced functioning of thyroid gland or because of an underactive thyroid gland. Now, hypothyroidism is a common endocrine disorder caused due to the deficiency of thyroid hormone. So, there is deficiency of T3 and T4. Now, before going into the details of hypothyroidism, let's quickly understand why the levels of TSH remain high in subclinical hypothyroidism and also in primary hypothyroidism. So, look at this figure. It depicts hypothalamic pituitary thyroid axis. Now, hypothalamus is located at the base of brain and it secretes TRH, that is a thyrotropin releasing hormone. Now TRH stimulates anterior pituitary to secrete TSH, that is thyroid stimulating hormone. Now this TSH further stimulates thyroid gland to secrete T4 and T3. Now required amount of T3 and T4 are constantly produced by the thyroid gland and secreted in the blood. But if thyroid gland secretes less amount of T3 and T4, then this condition is termed as hypothyroidism. Now let's understand what happens during hypothyroidism. So these reduced blood levels of T4 and T3 send positive feedback signals to hypothalamus. This causes stimulation of hypothalamus, and therefore there is increased secretion of TRH. This causes increased secretion of TSH, and so TSH is produced in an amount more than the normal, and this increased TSH constantly stimulates thyroid gland to increase the secretion of T3 and T4 so that this deficiency of T3 and T4 could be prevented. Now during subclinical hypothyroidism, constant stimulation of thyroid gland by increased TSH keeps the secretion of T3 and T4 normal. But over a period of time, even high levels of TSH, even high secretion of TSH is unable to prevent the deficiency of T4 and T3. So this is why the levels of TSH remains high in subclinical hypothyroidism and also in primary hypothyroidism, which accounts for 95% of all cases of hypothyroidism. Now let's classify hypothyroidism. Hypothyroidism is classified as primary, secondary and tertiary. Now very important, around 95% patients suffer from primary hypothyroidism where thyroid gland itself is diseased, and this thyroid gland is unable to produce required amount of thyroid hormone. So there is deficiency of T3 and T4. Now this reduced T4 and T3 in the blood causes constant stimulation of anterior pituitary, and that increases TSH. But this increased TSH is also unable to prevent deficiency of T3 and T4. So primary hypothyroidism is diagnosed by reduced blood levels of free T4 and free T3, and in addition to this, the levels of TSH are found to be high in primary hypothyroidism. Next is secondary hypothyroidism. Here the thyroid gland is normal, but the problem is associated with the pituitary gland. So pituitary gland produces less TSH, and this causes reduced stimulation of thyroid gland, and that reduces the secretion of T4 and T3. So this is termed as secondary hypothyroidism. However, this condition is usually rare. Next is tertiary hypothyroidism. Now here the functioning of thyroid gland is normal. Even pituitary is normal, but hypothalamus does not produce sufficient thyrotropin releasing hormone. That means the problem or the disease is at the level of hypothalamus. So there is reduced TRH, and because of the reduced TRH there is reduced TSH, and because of the reduced TSH there is reduced stimulation of thyroid gland, and that causes deficiency of T4 and T3. So it's very important to understand that it's the primary hypothyroidism that is common, and this primary hypothyroidism occurs in around 95% of patient population, and it is diagnosed by reduced free T4 and free T3 levels and increased TSH levels in the blood. Now let's understand causes of hypothyroidism. Let's first understand cause of primary hypothyroidism. Now worldwide, iodine deficiency remains the main cause of hypothyroidism. Now as we all know, iodine is required for the synthesis of thyroid hormone. So deficiency of iodine in the diet reduces synthesis of T3 and T4, and this causes hypothyroidism. Now in countries like United States with adequate intake of iodine in the diet, Hashimoto thyroiditis is the most common cause of hypothyroidism. Now this is an autoimmune disease where activated T and B cells of the body starts destroying the thyroid gland. Now hypothyroidism is also induced by the drugs like amiodarone. Now amiodarone causes excess release of iodine, and when the amiodarone is metabolized, it causes excess release of iodine, and this excessive iodine inhibits the synthesis of T3 and T4. Now in addition to this, amiodarone also inhibits peripheral conversion of inactive T4 to active T3. Then drugs like lithium. Lithium inhibits the release of T3 and T4 in the blood. Then radioactive iodine. Radioactive iodine, iodine 131, destroys the thyroid gland, and it can even cause permanent hypothyroidism. Now, even though iodine is required for the synthesis of T3 and T4, but excess iodine inhibits the synthesis of T3 and T4. So, the drugs like amiodarone, lithium, then radioactive iodine, excessive iodine can cause hypothyroidism. Another cause can be postpartum thyroiditis. Now it develops in around 10% women 2 to 12 months after the delivery. Now this type of hypothyroidism usually resolves on its own. Another cause of primary hypothyroidism is congenital hypothyroidism. Now congenital hypothyroidism affects infants right from the birth. Now non-development of thyroid gland is called as thyroid agenesis, while abnormal formation of the thyroid gland is called as thyroid dysgenesis. Now next is the secondary and tertiary hypothyroidism. Now this is also termed as central hypothyroidism, and this usually occurs rarely. Now main causes of central hypothyroidism are traumatic brain injury. This injury can cause damage to the hypothalamus or the pituitary gland. Then any tumor compressing the hypothalamus, this prevents release of TRH. Another cause of secondary hypothyroidism is the tumor of pituitary gland. Then Sehan syndrome. Now in this syndrome, massive or excessive blood loss or hemorrhage during or after the delivery stops the supply of blood to the pituitary gland. So this leads to the necrosis or the damage to the pituitary gland. So these are the causes of primary and secondary, tertiary hypothyroidism. Now let's understand clinical signs or manifestations of hypothyroidism. Now first and the most common sign of hypothyroidism is the goiter. Now as we know, TSH blood levels remain high in subclinical as well as in primary hypothyroidism. So constant stimulation of thyroid gland causes enlargement of the thyroid gland, which is termed as goiter. Now second, as we know that the main function of thyroid hormones is to regulate the basal metabolic rate, that is BMR. So first let's understand what is this BMR. Now BMR is the amount of energy required by the body at rest to maintain vital functions of the body, like for example functioning of heart, functioning of kidneys, lungs, etc. Now this energy is derived by the burning of calories in the food. Now when calories in the food are burnt, energy as well as heat is generated. Now hypothalamus reduces BMR. So BMR is reduced during hypothalamus. So less calories are burnt and this causes weight gain. This also reduces appetite. Now reduced BMR reduces generation of heat. So this reduces body temperature and can cause cold intolerance. Then T3 and T4 regulate heart rate, contractility of the heart. So hypothyroidism causes bradycardia. That means heartbeat at rest reduces to less than 60 beats per minute. Then T3 and T4 are also essential for the development and growth of the body. So hypothyroidism causes reduced bone growth and maturation, and this causes short stature or reduced height in the children. Now in addition to this, depression, fatigue, lethargy, that is tiredness, are also common in patients of hypothyroidism. Now hypothyroidism reduces gastrointestinal motility, leading to constipation. Now T3 and T4 regulate development, contraction and regeneration of skeletal muscles. Thus reduced muscle contraction, myopathy, muscle weakness are observed during hypothyroidism. Now hypothyroidism also causes hair loss, brittle nails, the nails break easily, and dry skin. Now reduced T3 and T4 stimulate the hypothalamus, and this increases the secretion of TRH from the hypothalamus during hypothyroidism. And this increased TRH stimulates anterior pituitary to increase the production of prolactin. Now high prolactin levels inhibit the secretion of follicle stimulating hormone, that is FSH, and also reduce secretion of LH, that is luteinizing hormone. Now reduced FSH and reduced LH reduces ovulation and spermatogenesis, causing infertility. So infertility is also one of the manifestations of hypothyroidism. Hypothyroidism also leads to increased LDL, that is low density lipids, and triglycerides in the blood. So these are the signs or manifestations of hypothyroidism. So after discussing hypothyroidism, its types, causes, manifestations, now let's understand pharmacology of L-Thyroxine. Now L-Thyroxine is levothyroxine. It's a synthetic analog of natural thyroxine, that is T4, and it is used for the treatment of hypothyroidism. Now levothyroxine is given orally or by intravenous injection. Now let's understand the pharmacokinetics of L-Thyroxine. Now oral bioavailability of L-Thyroxine is approximately 75%. Now more than 99% of circulating L-Thyroxine remains bound to plasma proteins like thyroxine binding globulin, albumin, etc. Now very important, L-Thyroxine is administered once daily, empty stomach, to avoid interference with the food, and preferably it is administered early morning along with a glass of water 1 hour before the breakfast. Now very important, like T4, that is like thyroxine, levothyroxine is also inactive. So levothyroxine is deiodinated. It is deiodinated in the organs like liver and kidneys. So one iodine is removed from levothyroxine and levothyroxine is converted to its active form, that is triiodothironine, and this triiodothironine is then released in the circulation. Now, levothyroxine has a long half-life of around 7 days in hypothyroid patients, and therefore it is administered once daily, and this provides sustained and uniform action. Now, levothyroxine is mainly excreted by the kidneys around 80%, and remaining 20% is eliminated in the stools. Now, L-Thyroxine is available in various strengths like 12.5 microgram, 25 microgram, then 50, 75, 100, 150 microgram, and various other strengths are also available. Now, dose of L-Thyroxine is based on the laboratory test, primarily blood levels of free T4, free T3 and TSH, and therefore it often requires titration. So, the dose is decided and titrated, that is, dose is changed by the clinician. Now, let's discuss few drug interactions of L-Thyroxine. Now, drugs like sucralfate, iron, then calcium, proton pump inhibitors interfere with L-thyroxine and reduce the absorption of levothyroxine. Then cytochrome 3A4 enzyme inducers like for example rifampin, carbamazepine. These drugs accelerate or increase the metabolism of levothyroxine, so dose adjustment is required and it is made by the clinician. So doses are adjusted as per the requirement. Now, very important indications of L-thyroxine. Now, deficiency of T3 and T4 is fulfilled by the administration of L-thyroxine. So, L-thyroxine is used as a replacement therapy in hypothyroidism. So, first indication is cretinism. Cretinism is hypothyroidism in neonates, infants and children. Now, if not treated, it leads to physical and mental retardation. So, treatment should be started as early as possible. Physical growth and development are restored in the child and mental retardation is prevented. Another indication is myxoedema. This is hypothyroidism in adults, and treatment is started with a low dose and the dose is increased as per the discretion of the physician. Then subclinical hypothyroidism. So, as already discussed, in subclinical hypothyroidism, free T4 levels remain normal, but TSH levels increase. So, TSH levels more than 10 milliunits per liter are treated with L-thyroxine. Then myxoedema coma. This is an emergency situation with severe hypothyroidism. Rapid thyroid replacement is very essential. So, L-thyroxine IV is initiated and this is followed by oral therapy as per the discretion of the physician. And since this is an emergency situation and can cause significant mortality, other essential supportive measures and drugs are also used by the physicians for the management of myxoedema coma. Another very important indication is the non-toxic goiter. Goiter is the enlargement of thyroid gland. This is non-toxic goiter where there is deficiency of T3 and T4, and thus continuous stimulation of thyroid gland by TSH causes enlargement of the thyroid gland, which is termed as goiter. Now, administration of L-thyroxine reduces TSH and this regresses goiter. That means it reduces the size of the thyroid gland. Next use of L-thyroxine is in thyroid nodules where TSH levels are high. So, L-thyroxine reduces the levels of TSH and bring them to normal, and this causes regression or reduction in the size of thyroid nodules. Another use of L-thyroxine is in papillary carcinoma of thyroid responding to TSH. Now, therapy with L-thyroxine reduces TSH and this may induce temporary regression or reduction of the cancer. So, these are the main indications of levothyroxine. Now, very important, levothyroxine should never be used for weight loss or to reduce the levels of cholesterol in the blood. It should always be used in consultation with a physician, and the prescription should always be properly followed. Now, adverse effects of L-Thyroxine. Now, adverse effects of L-Thyroxine often result from the incorrect dose. Now, high doses of L-Thyroxine produce adverse effects like tachycardia, arrhythmias, anxiety, diarrhea, increased liver enzymes, menstrual irregularities, headache, etc. So, this is in brief on the use of thyroid analog, that is L-Thyroxine, as replacement therapy in the treatment of hypothyroidism. Now, please note, information provided in this video is meant only for students from examination point of view. For clinical use of L-Thyroxine, consult your physician. L-Thyroxine should be used only if it is prescribed by the physician. And if you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.